Welcome to the Renal Physiology Review of the Falcon Physician Review Online. My name is Sunil Udani, and I will serve as your instructor through the Renal Physiology Review. In this course, we will go through an overview of renal physiology, starting with basic renal anatomy, walking into more detail into renal anatomy, and then walking through renal physiology first as an overview and then in much more detail. Hello, and welcome to the Renal Physiology course. My name is Sunil Udani. I'm a nephrology fellow at the University of Chicago Medical Center. I will be helping you walk through the renal physiology portion of the USMLE Step 1 review course. We will start with basic gross anatomy, move on to functional anatomy to serve as a background prior to delving more in detail into renal physiology. The material, as you will notice, will oftentimes repeat itself. The purpose of this is to reinforce important concepts. We will walk through renal physiology from different angles to help you better understand the material. First, let's start with the gross anatomy. Before going into the anatomy, let us start with some basic concepts. First is the concept of homeostasis. It's important to recognize that the kidneys regulate body fluid and electrolyte balance by producing urine and regulating the volume and contents of urine. The kidneys excrete metabolic waste products as well. And finally, the kidneys play a crucial role in the regulation of total body fluid volume and intravascular volume, body fluid osmolarity, serum concentration of various electrolytes, including sodium, potassium, calcium, phosphorus, etc., and acid-base balance. The first step in the production of urine is glomerular filtration, in which large amounts of water, electrolytes, and small molecules are filtered out of the blood. The filtrate produced contains roughly everything present in the blood except for blood cells and large molecules as proteins. The kidney modifies the contents of the filtrate to produce urine. As we mentioned, the kidney is responsible for maintaining homeostasis. In order to achieve this, the kidney must modify the glomerular filtrate into the final composition of urine. It does this by modification processes. The two major modification processes include reabsorption of useful substances and secretion of unwanted substances. For example, the vast majority of water, sodium, glucose, and amino acids are reabsorbed from the filtrate back into the bloodstream. The reabsorption process in the case of water, sodium, and the other electrolytes is highly regulated to maintain fluid, electrolyte, and acid-base balance. This allows the kidney to, depending on the intake of in the diet of water, sodium, or other electrolytes, to modify that so that these electrolytes and water balance are maintained within a very fixed specific range. Secondly, the kidney modifies the filtrate through the process of secretion. Unwanted substances, such as toxins, are either simply left in the filtrate to be excreted in the urine, or, to a lesser degree, actively secreted by the kidneys into the urine. Important to remember is the kidney is responsible for the excretion of water-soluble or hydrophilic toxins only. Water-insoluble or hydrophobic toxins are dealt with by the liver, which either excretes them into bile or converts them into a water-soluble form. Outside of the maintenance of homeostasis in the terms of salt and water balance, the kidney also performs important endocrine functions. They produce erythropoietin, the hormone that stimulates red blood cell production in the bone marrow, and they secrete renin, which helps regulate blood pressure and electrolyte balance. They also help maintain serum calcium levels by producing calcitriol, the active form of calcium-regulating hormone, vitamin D. Now that we've outlined those basic concepts, let's go through the basic renal anatomy. This is an image of the gross renal anatomy. The important things to remember are there is the renal pelvis, where the renal vein, renal artery, and ureter enter and exit, the branching segments of each of these go deeper into the renal cortex and the medulla, which forms the functional units of the kidney. Also important to remember is the kidneys lie within the retroperitoneum. The right kidney is slightly lower than the left. Each renal hilum transmits the renal arteries and veins, renal pelvis, and autonomic nerves to each kidney. Each ureter descends in the retroperitoneum anterior to the psoas muscle to the pelvic brim, where they cross over the iliac vessels. You will see on this image 3 spots denoted numbers 1, 2, and 3. These spots are denoted for they are the places in where kidney stones are most likely to become lodge and cause symptomatic obstruction. The other thing important to remember is that the renal blood supply comes directly off the aorta and the inferior vena cava. You can see in this image that the left kidney, the renal vein going to the left kidney must traverse the aorta. This becomes important in the setting of renal cell carcinoma, where renal vein resection is often necessary. Depending on where the renal vein lies in relation to the aorta, this can make a surgical excision more or less complicated. This is an important clinical correlation to know. The obstruction of the ureter by a kidney stone normally occurs in one of 3 places. Those 3 places outlined in the previous slide. Going from superior to inferior, in the renal pelvis, the uretopelvic junction, or otherwise known as the UPJ. The other next inferior spot is the pelvic brim, at the location of the iliac vessels. Finally, it can occur at the uretovesical junction, or the bladder wall. If you note, all of these points are important transition points where the ureters are passing over another large structure, first being the renal pelvis itself, secondly being the iliac vessels, and third being where the ureter enters the bladder. These are important to remember, as these are the most common sites of obstructive nephrolithiasis or kidney stones. The kidney can be imaged by multiple different modalities radiographically. Most commonly, we use plain ultrasound to visualize the kidney. The image on the left is an image of hydronephrosis, or obstructed collecting system of the kidney. This is a longitudinal view where you can see there's a dilated renal pelvis suggesting obstruction distal to that point. The image on the right is an MRI image of the kidney, also showing obstruction with hydronephrosis and hydroureter. The kidney can also be imaged by plain CT with or without intravenous contrast. Plain X-ray in the past was used to visualize the kidney. However, with the readily accessible CT scanners and ultrasound machines, this is less often clinically useful. In the case of symptomatic nephrolithiasis, extracorporeal shockwave lithotripsy is a process used as one possible treatment. This is a procedure used to shatter simple stones in the kidney or the upper urinary tract. Ultrasonic waves are passed through the body until they strike the stones. Sonic waves pulverize the stones, which then more easily can be passed through the ureter and out of the body into the urine. Most often, however, stones are passed without any specific intervention. Important, though, in patients with kidney stones, the objective is to catch a sample of the kidney stone to allow for chemical analysis to better understand the source of why the person developed kidney stones. Renal blood flow is important to understand because the kidney relies on its large blood supply. Over 20% of the cardiac output with each cardiac cycle goes to the renal vessels. It is the organ with the highest blood flow per weight and lowest oxygen extraction, and renal function is profoundly dependent on blood supply. From a clinical standpoint, most of the cases of deranged renal function encountered are a result of true or effective derangements in renal circulation. With regard to renal blood flow, it's important to remember that the renal arteries arise directly from the aorta. Once they enter the hilum, the main renal artery branches, and it branches into the interlobar, the arcuate, and the intralobular arteries. Ultimately, all these arrive into the afferent arterioles. The afferent arterioles are present in the glomerulus and will form part of the individual functional units of the kidney. This concludes Section 1 of the Renal Physiology Review. The key points to remember from Section 1 are that the kidney is responsible for maintaining homeostasis, that the kidneys lie within the retroperitoneum, and the kidneys are highly dependent on blood flow and receive approximately 20% of the cardiac output with each cardiac cycle.